let's go about talking about the less politically polite phases of this, and you alluded to it. All right, we'll just dive right in. Quality of life and quality of adjusted life years. Now, you can say this any way you like, but some politician's going to come back and say, you're rationing. You're saying, how much is the human life worth? And some pol is going to say it's worth everything. Every second is worth something. So discuss the importance of evaluating quality adjusted life years in comparative effectiveness research in oncology, and the heck with political correctness. How do you do it? Anybody want to jump in? You want to jump in?
Sure. I mean,
good.
I think that the data will be collected, and then the political third rail will be when that data that's collected gets analyzed and then turned around to set future policy.
Okay. So you're telling me we're going to know what we need to know. That somebody is going to say, this 90-year-old patient, and here comes the term that's just loaded, is not cost effective to treat this way. And somebody else is going to scream, that's my mom. Mm-hmm. Now what do you do?
So
I think, go ahead, Mike.
So, I think quality is one tool. I think quality, for the reasons that you say, is a problem. But it's not the only tool. So we can turn it around another way. And I think comparative effectiveness research will be tremendously empowered if it finds a way to include patient-reported outcomes. So let's say that mom is 90 and you know what's important to mom and you know what happens to 90-year-olds who get this treatment because of your comparative effectiveness research. So if it's my mom and she doesn't want to spend her last month in the hospital, that's a pretty easy sell. Okay. Now the question is that enough? Should that drive policy? Or should that just be informative for consumerism?
For an individual decision, right?
So, right, I think he's hitting on. I mean, I think there's some utility in being able to rank order, and I'll build out on the idea that if we can get some of the worst stuff out of the system, or at least understand where its application best rests, could be some real utility to that. Mm-hmm. But the idea of rationing here.
I mean, look, the rationing word is simply out there. It's on the table. What you hear, however, what I hear from families is, well, are you going to do something for mom or to mom? Really. And some of the very aggressive therapies that mom doesn't want, the family doesn't want, and it hasn't come to the level of policy. It's just that it's common sense, right? And I think that the issue comes up, and I'm going to ask you to just address this. Can cost discussion really result in the one thing that critics fear, which is rationing? I mean, can there be, is a foreseeable future in which we simply say no? This is too expensive, this is not efficacious, grandma can't have it no matter what grandma wants.
Wow. That really is the third rail that was alluded to earlier.
I powered it up.
Yeah,
Feel free to step on it.
Yeah, well,
But I mean, for the first time, we've got ethicists saying, you need to be talking about cost.
Well, that's right. And the problem is that John Q. Public, Mrs. Smith, the 90-year-old and her family, they have no idea of cost. So it becomes the question, is it the provider, the doc who's taking care of her, his obligation to discuss cost with them? I think that, as was said, if you're 90 years old and you want mom or dad to suffer through this, and these are the side effects of these drugs, I mean, it's like I used to say to patients, I can add probably a lot of years to your life or some years to your life, but I'm not going to add a whole lot of life to your years. And what price are you willing to pay for that? And I think that's where the discussion should go.
But you see, what you've just described is a discussion. Right. And what the critics are afraid of is that the discussion doesn't occur at all. That it occurs somewhere at a policy level, and somebody says, no, we've made the decision, grandma can't have it, even if grandma wants it.
Well, I would hate to be in that situation. I mean, now you're really taking a page from Zeke Emanuel's philosophic diatribes that he gets into, and I've met Zeke a couple of times, and I sometimes want to choke him.
That's the next panel discussion.
That's the next panel discussion.
Important note to our viewers: if something happens in a choking way to Zeke Emanuel,
right. That's just metaphorically, metaphorically only. But it is a difficult discussion, and I'm not sure that, I think it's coming. I'm not sure we're going to see it in our lifetimes. But I think that these discussions on cost and population dynamics and control are coming, but
Yeah, and they have
not
to.
tomorrow.
And they have
And they
to,
have
because
to.
every dollar that we spend on
Right.
healthcare is one less dollar we spend on roads and schools and education, that kind of thing. And but while we're happy to debate class size and school funding, we don't talk about healthcare costs. And I think that really leads to what you were talking about, Erwin, earlier, is that discussion. We don't have to ration healthcare if we make sure that patients understand what they're getting. And especially around end-of-life care, third, fourth lines of therapy. If patients don't understand that there might be other ways of getting the outcomes they want without getting additional therapy, then that's a savings without having to ration anything. And in our experience in working with providers to do advanced care planning around patients who have terminal diseases, a lot of patients, once they fully understand the options, say, you know, I don't want more treatment. I want to be kept comfortable.
Some do,
I agree.
some do.
I think that's 100% right.
And some do. But my point is that if we give everybody everything without asking to make sure that the treatment we're giving is
give what they
consistent
don't
with their
want.
wishes, yeah.
Right, but some
yeah.
of them they won't want, some they will.
Yeah.
The most telling data is that when you survey oncologists about what they would do for themselves in these circumstances, they more often than not choose not to receive therapy given what they know about the risk and benefit of treatment. So that tells me that we have done a very, very poor job of communicating with our patients what the risks and benefits of these approaches are.
Well, haven't we
and
oversold
there's a
what we can do?
Ton. Of course, there's a oh, don't even get me started.
Why not?
There's
This
a
is good television.
tremendous opportunity,
Yeah.
right? Tremendous, so much low-hanging fruit of just reestablishing trust with the patient, finding a way to communicate effectively around risk and benefit. Don't even talk about the cost, it's irrelevant. Talk about, why would I do this? What am I going to get out of it? And having a good dialogue about that.
Let's come back to cost for a minute. Can this